Okay, everybody, this is the seizures presentation. I know you guys can wake up. If you're listening on mobile, I am sorry. There will be rustling noises on headphones, so please be careful of that. If you're listening on your laptop, turn the volume up. I'm not sure how the audio quality will be, but I will be popping in and out on this video screen to keep you all engaged. I know it gets boring listening to long lectures and all that stuff, so I'm going to try to keep it interesting. In case this video gets used in the future, a little introduction about me. My name is Omer Nader. I was Chief 2017-2018 of UEMR, then now serve as Captain for 2018-2019, the year that this video is being made. 2019 is the year this video is being made. So yeah, by the time, if this does get reused, you will have better captains, better chiefs than I have ever been. And I'm almost confident in saying that. So without further ado, we are going to have fun, and we are going to have an awesome seizures lecture. Big thing I want to say before we really get into the nitty-gritty is that the details do matter in seizures, because the quicker you recognize that this is some type of seizure emergency, the quicker you can rule out AEIOU tips. On the other end of AEIOU tips, all of those other ones, but you can also start investigating the cause of the seizure, which happens to be some of the AEIOU tips, some of the parts of that mnemonic that you guys will use. So I want y'all to be very well versed in AEIOU tips by the end of this lecture, but in general, for your EMS education, you guys should be very well versed in AEIOU tips, because it's a great altered mental status tool. And I know I use it when training my attendant, and I'm sure all the other field training officers also use it as well. So here we go. I will pop out for a little bit and I'll come right back. So seizures. So the reason why I put this abyss of kind of this forest mountain and with this one, I think that's two backpackers. It looks like, I don't know, it's a visual illusion. I think it's one backpacker, but who knows? This one backpacker on a long journey on a bridge going towards something that they do not know what's at the end, right? And some of y'all may feel like that is you, right? I know that is me a lot of the times on calls, and who knows who's listening or whatever, but a lot of the times we don't know what we're doing, right? A lot of the times we're out of our depth in terms of BLS scope of practice. Right, and that may lead to some type of confusion on scene. Absolutely, right? It happens to everyone, right? But what we're doing now in terms of training is supposed to train y'all in doing what you can do within your BLS scope of practice. So this character that we have, which could represent you on a bridge towards treating that patient, you don't know what the end will be. It depends on that patient, right? But you know how many steps are on that bridge, how to hold the sides of that bridge, and how to get to the end, right? And weird analogy, but we're going to keep going with it, all right? I'll be right back. So, seizures, next one. Again, an unrelated photo. I don't have a long-winded story about this one. This is just blurry cars in a building. We're going to talk about the types of seizures, the causes of the seizures, which is what I really want y'all to kind of get in your brains for this training, is the causes of seizures and the treatment, right? And you'll notice that our treatment is very simple, right? So investigation will be the name of the game for this one, investigation. UEMR specific protocols we will discuss as well, right? And then we're going to do some fun knowledge checks at the end, so I'm going to pop back in at the knowledge checks and maybe in between to have some fun. Okay, so the types of seizures, right? The generalized types of seizures, what you guys imagine maybe normally is a tonic-clonic seizure, right? They were formerly known as grand mal seizures, right? Tonic means stiffening, so a patient will stiffen up. And then clonic means rhythmic jerking, right? So that could be, just like moving around, jerking motions, active, people think actively seizing. They usually see the clonic phase of rapid movements. So this is a cycle you'll see of the tonic-clonic. You go aura, loss of consciousness, tonic phase, repeat, or you go postictal. That means all that tonic-clonic phase is over, and then you're in a postictal phase. But what we want to take away from this first part of tonic-clonic is aura here first, right? What do you think an aura may be? You can pause the video and ask yourself, maybe repeat 3 things back to yourself, and then we'll come back. An aura is it's shown by research that an aura is some type of feeling that someone who's had a history of seizures or someone who doesn't have a history of seizures, it's some type of feeling they get before having a seizure. So what that means, and this is backed by research, that people have reported seeing flashing lights, smelling an unpleasant smell, tasting something that is either unpleasant or really pleasant sometimes. It just depends on the person, right? Some people taste all kinds of things. And then confusing thoughts. Now, it's not to say that all confusing thoughts will lead to some type of tonic-clonic seizure, but in some reported research cases in journals, there has been saying that some patient will just become very confused and then go into a seizure. All right, so that's your tonic-clonic phase, and that's the aura of the tonic-clonic phase. Excuse me. Your loss of consciousness. Obviously, they will lose consciousness if they're going to have a seizure. That's part of it. Right? There's too much electrical activity going on in the brain for them to stay alert and awake, so they will lose consciousness. You have the tonic phase, clonic phase, and then here's what I want to really talk about right here is the postictal phase, right? This is where EMR really comes into account in terms of saving RFD a lot of time, a lot of resources, but also, we get to really investigate our altered mental status patients, right? That we really get to use our protocols on that one. And as you all know, you have to remember that postictal patients are upgraded to a captain at bar none, always, right? That's written on your upgrade criteria, right? So we really need to pay attention to this postictal phase. And we'll come back to it on our knowledge checks, but I just want y'all to really focus on the postictal phase, right? Which relates to the time, right? Because you want to know how long they've been in that state or how long they have been actively seizing, right? Because they'll either repeat or go into postictal, all right? So keep that straight. Sorry. Pseudo seizures. These are actual seizures. Don't get me wrong. They're just called pseudo. It's a bad name for them. But they can be triggered by stress, anxiety, but they're often a result of mental health complications with underlying issues, right? Mental health complications with underlying issues are a big deal for EMR. Absolutely a big deal for EMR. We want to make sure we rule out underlying issues before releasing a psychiatric patient. So if you see a pseudo seizure, right, and they're postictal, and they have a history of all these mental health illnesses, we have to keep that in the back of our mind that we really have to rule out a lot before we let that psych patient go if they're in a pseudo postictal phase. Pseudo is a bad word for it. A postictal phase after their kind of pseudo seizure, and there might be stimulants that cause this type of seizure. All right, so you want to remove your patient from that environment, but you also want to just attempt to de-escalate, right? When they come back out of that pseudo seizure phase, out of really just the kind of jerking motions you'll see in a pseudo seizure, they'll be kind of postictal, but really they'll just be really altered, like a psych patient would be, just after they have an episode. So you really have to, either de-escalate, calm them down, talk them through it, and really investigate AEIOU tips. And as you know, the P in AEIOU tips is psychiatric, so we really have to investigate that. Moving on, absent seizures. They can look postictal is just them staring off in a distance. They're very quick. And they're mostly in pediatric patients. So we are going to table that one because absent seizures are usually treated in the clinic. But again, they're just very quick. So I hope no one's really calling for that, but we have to always make sure that we know that type of seizure. And then febrile seizures as well in pediatric patients. That's what we really have to look for. I'm going to show the protocols in a minute, but the age ranges for a febrile seizure, so is 6 months to 6 years. 6 and 6. 6 months, 6 years, right? Any time in between that is you have to be aware of febrile seizures that could be a possible reason for that electrical activity in their brain. So if it does come to febrile seizure, and you'll see the protocols in a minute, you treat with acetaminophen and ibuprofen or both, dependent on your temperature ranges. 100.4 to 102 is acetaminophen or ibuprofen without ingestion in the last 4 hours, and then greater than 102 is you do both. So remember that for your fever protocols. And then a partial seizure. Partial is not a term they use. It's moving. They're moving away from partial. So the term I want you all to remember can be partial, but it's focal onset aware seizures, or you could have focal onset impaired So this is where epilepsy falls in, right? So you may have repeated movements as a sign that they're going through a partial seizure. There could be lip smacking. There could be really fast chewing. Eyelids are fluttering. That's what you guys mostly see sometimes. Hand rubbing can look OCD a lot of the times. But physiologically, what's happening in a partial seizure is you start on one side of the brain and then you move over. So the reason why some people can have full awareness is you're only on one side of the brain. So your other side of the brain's still working. So you can, have full awareness maintained. But the rhythmic movements, as that second bullet point states, are not tonic-clonic, right? You're not stiffening up like a tonic motion, right? You're just having repeated movements that you look lucid enough. If you're impaired, obviously you're impaired, altered mental status, you're going to go through your protocols, your AMS protocols. Okay. Let's continue. So here are your protocols, all nifty and dandy, ready for you all. I know you guys don't like the pink side of this, but we're going to focus on this side first, and then we'll get to the pink side. So as you can see, there's only 2 Roman numerals here, right? But what the notes say is what's the most important part here, right? You all know ABCs, right? ABCs. Oxygenation, ventilation, airway patency, right? These are all ABCs. This is what we do for everyone, right? But here's the AEIOU TIPS mnemonic for underlying causes of the seizures, right? And we'll get to status just in a moment. But remember, investigation is the name of the game. You guys have to investigate, right? Because that's the best service you can do for any responding EMS service like RFD, or in general, you want to know the reason why something's happening. So AEIOU TIPS, investigation is the name of the game. So what are we doing, right? We're maintaining an SpO2 of 94. Absolutely. We're supporting and assisting respirations as needed. Absolutely, right? Airway patency, the only reason why airway patency would not be, the only reason why your airway would not be patent is your tongue. Your tongue can be a really big airway blocker. And if for people having seizures, their tongue will fall back on itself and block the airway. Right, that's why there's, their oxygenation will fall if for extended period of times if they're having a seizure for an extended period of time, right? So make sure you check for their SpO2 levels, you check for cyanosis, you're really trying to make sure that they're ventilating correctly, they're perfusing correctly and everything, right? So you want to maintain 94% SpO2, right? And that comes with airway patency and ventilation. That's if they're actively seizing, right? It's same on both sides for pediatric and adult. If they're in postictal, again, they're coming out of the seizure, so you have to maintain their SpO2 because they could have had airway blockages before, and now they're awake. They have control of their tongue. But their second bullet point and the third bullet point as well in pediatric relates to investigation, right? Special attention to blood glucose levels, overdose, sepsis, heat emergency, hypoxia, trauma, mental status improvement, right? These are all things that you can investigate via AEIOU TIPS, right? And again, looking at the pediatric side, Febrile in nature, administer acetaminophen per fever guidelines. Fever guidelines is what I said earlier. Acetaminophen or ibuprofen, you guys can look at the dosages another time or rewind back if you want to see which ones you want to do. Just to refresh my memory, acetaminophen is 15 milligrams per kilogram. Ibuprofen is 10 milligrams per kilogram. So rewind if you want to see if you want to hear the temperature ranges, and then you can come back and you can get the dosages. Sorry about that. So on the pediatric side, if we focus our attention there, febrile seizures is there, 6 to 6. Remember your 6s, right? And now we have status epilepticus. This is something that's a big deal. It's a really big deal, right? It's seizures lasting more than 5 minutes, so there's no break, right? And that's a big deal because you have possible airway compromise, right? Their tongue is covering their airway, right? You could have their oxygenation or their perfusion can be an issue. Their oxygenation will definitely be an issue, right? There's just a lot of issues that'll come up with a blocked airway. So status is a big deal, and and the big thing about status is time. You want to investigate time. Time is so important, right? It's just like a stroke. Everyone's going to wonder, if someone's in status, they want to know how long, right? They want to know how bad is their airway compromise potentially going to be, right? And that comes with, your SpO2 values and your cyanosis, but you want to know the time. So whenever you're getting on scene with an altered mental status patient, right, you just want to know the time, right? And that's, you guys are always going to ask because you guys are great EMTs. But as a refresher, always ask for time. And this catecholamine rush that comes with status, right? And again, it's catecholamine you might not get right off the top of your head, but the catecholamines are dopamine, epinephrine, norepinephrine, right? These are the response hormones, the stress response hormones, sorry. They result in elevated BP, elevated heart rate, elevated blood glucose level, right? Dysrhythmias, hyperthermia, right? Imagine just working overtime, just moving a lot, right? And what comes with that. Hyperglycemia is just elevated blood glucose and may not come from moving a lot. You get a low blood sugar, whatever, right? But you really want to think about it like the catecholamines, the epi, the norepi, the dopamine. It's all leading to that stress response that we have all studied in Bio 2 and biochemistry. For those who have not, I am so sorry, but you guys should get this, right? In the catecholamine rush, you'll see your patients in a postictal state will obviously have probably upgrade criteria level BP or heart rate, but for sure on the high risk level, right? Just depending on their normal limits. So again, we should know what's happening in terms of the seizure because of airway blockages, and then the catecholamine rush will make everything even worse, right? But what are we doing in terms of EMS? Or in terms of EMR, we are maintaining their airway and their oxygenation/ventilation. Okay. Sorry to be long-winded, but these first two bullet points are active. Like these are what you're going to use actively throughout, like all of your EMS calls for sure. Right? You just want to make sure their ABCs are patent all the time, right? And then these ones, this is all investigation right here. Okay, moving on. Sorry. Oh, the common causes of seizures. So this chart is probably what you all recognize from your big orange books out of EMT school. If it is orange, I can't tell. But it's hard to memorize it like this, right? There's all these letters everywhere. You don't know what's going on, right? You have febrile at the bottom. It doesn't make sense, right? But if you guys want to, learn it this way, you guys like this way, structural versus metabolic, absolutely give this video a pause, and we'll meet you after you come back. But this is the way I like to think about it, right? AEIOU tips. I'll keep hammering it in, right? And there's a question at the end about it too. So make sure that you guys really are thinking about this. Alcohol withdrawal, for sure a cause of seizures, right? Alcohol is part of the A, right? There's acidosis, ammonia, arrhythmias, right? Of course, right? These could be reasons for altered mental status. But alcohol withdrawal is a very common one, right? Epilepsy, look for the bracelet, right? Epileptic, like either they will tell you when they're postictal that, yes, I'm an epileptic, I've been off my meds, my doctor told me to, which is fairly common around UTD for some reason, right? Or they'll have a bracelet, right? So usually the Good Samaritans, the really Good Samaritans have a bracelet. If not, you just got to find out by investigating. Infection, brain abscesses, they'll usually tell you upon investigation if they have a brain abscess or some type of infection or something going on. If they know they've been sick for a while, that could cause it. But again, if they're sick, you're going off of so many other bells. You could be looking at sepsis. You could be looking at other things. So infection is definitely a cause of seizures, but is also a cause of other altered mental status protocols. So that one's a little harder. But again, can cause seizures in the brain. Can cause seizures due to brain abscesses, and that really leads to brain hyperactivity. Overdose and hypoxia. Hypoxia for sure can cause seizures, and the overdose, absolutely, right? You overdose on any type of medication, right? Then that can lead to seizures, right? We've had a history of patients with kind of different types of substance abuse that have resulted in seizures. Just regular recreational drugs, regular meaning what people normally take for recreational drugs, and those have resulted in seizures, right? And that's an actual really big deal. So remember that overdose, regardless of medication, right? Overdose, if you have too much of it, it results in higher electrical activity. Uremia, that's usually in renal failure. Renal failure patients know they're in renal failure, but again, you just got to know that, and you really have to understand that people in renal failure will have a history of kidney disease. They won't just wind up in your lap with excess renal failure. If they do, power to you, RFD. There's going to be a lot of criteria for RFD upgrade anyway, right? So don't be worried if you have to figure out of uremia. Trauma, really consider trauma in this one, right? Because one hit to the head and you can go into a seizure. It happens, right? So really consider trauma. And trauma can lead to altered mental status and all that, right? So again, the common theme here is that altered mental status protocols really help you on seizures. That's what I want to really hammer through. Temperature, consider febrile, under 6 years, above 6 months, remember 6 and 6. Another thing I want to really hammer, I guess. And then tumors, they may not know if they have a brain tumor or not, but again, there's no way for you to tell that, so we can move on. Insulin hypoglycemia, again, all altered patients, you should be getting a blood sugar. You absolutely should be getting a blood sugar. There should be no doubt about that, okay? And then now we have poisons, right? This is what I really want to talk about this, actually. Poison. All medications can be considered poisons if you take too much of it, right? Or if you underdose on your medication, right? That could lead to some type of toxic level of something in your body, right? So all medications can be a source of seizures, right? I'm not saying like Tylenol is going to give you a seizure, right? But, people who don't take their meds, can wind up with seizures, right? And then poisons in general can cause seizures as well. Right? Pregnancy, eclampsia, right? Preeclampsia results in hypertension. Eclampsia is the actual seizures part of it, right? So we got to know that, right? And you all know that from EMT school. But these are all things for you to make sure you check off on your list of AEIOU tips to make sure you guys know which way this might go in terms of altered mental status, and that's how they're going to present on scene if they're postictal, right? If they're presenting as actively seizing, you guys know the drill, right? That's an upgrade criteria. So that's pretty easy, right? You guys just upgrade to RFD, you maintain their ABCs and send them off and try to get as much information as you can, right? But this you really got to investigate, right? And then stroke's a big one. We've had, some. So make sure you guys know for stroke, what's the biggest thing? You want to know their last known normal time, right? You want to make sure you're considering everything about them, making sure their ABCs are as patent as possible. But again, time is the big one on stroke. Okay, long-winded again. Sorry, slides are taking forever. So I'm coming back to this because you all should know now the causes behind it and the treatments of what we're trying to do in terms of EMR's treatments, right? What are we trying to do on the EMR BLS level, right? We're trying to give them everything that we can, but really, what are we doing? We're investigating. That's what we're doing. We're investigating. Right, we don't have the medications to stop seizures, so the only thing we can do is gather information and support their ABCs. All right, really hammer that in. Okay. So this is a funny little graphic that's actually very useful. First aid for seizures. This is just for a bystander, but usually we should know more than a bystander. So I will start with the basic, and we'll just kind of go through it. Cushion head, remove glasses. You just want to make sure they don't smack their head on the ground a bunch of times if it's a tonic-clonic. Loose and tight clothing, again, that could be an airway constriction. I just made my voice a little funny there. Okay. Turn on their side, left lateral recumbent, if there is, a type of secretions from their mouth or anything that could potentially block their airway. Again, airway reference. Hello. Time the seizure with a watch. That's huge. Time is huge. All right. Remember, time is huge. Don't put anything in their mouth. I know you guys don't do bite sticks. Please don't put anything in their mouth. Look for an ID, right? Again, the really, really good Samaritans will have the epilepsy bracelets, right? But you never know, right? Don't hold them down. Don't prevent their movements. Just keep them safe, right? Move everything out of the way, right? If they're in a classroom, spread it out, right? You can move tables. You can move chairs. If it's bolted down, then you got to just, put something in between. But just don't just, constrict them, right? That's the worst thing you can do. If they're actively seizing, just cushion them. Let them have their seizure episode. Make sure you know the time and, really take note of the time, but don't hold them down. Okay. And then now as the seizure ends, they might go into postictal phase or go back into a tonic-clonic phase or depending on the seizure, whatever, right? We offer help, right? And this could be any EMR provider. You just, put the faces inside the bodies, whatever. Okay. Right, so your first moves, I like to teach it this way. In terms of treatment at the EMR level, right, you upgrade for actively seizing patients. That's an easy one for y'all. If you're actively seizing, you upgrade. Or if you're actively seizing, sorry. If your patient's actively seizing, you upgrade. Then you support the ABCs, right? We always consider the tongue. because the tongue is the major sign of airway blockage. C-spine, of course we consider C-spine because it's probably an unknown mechanism. The patient can't tell you. Someone else maybe could tell you, but not really. Right? So consider C-spine for sure. But remember, ABCs come before C-spine because imagine trying to put an airway in someone with a C-collar on. It's not fun. Probably can't do it. Right? Protect the patient. We just talked about that. Vitals, your blood glucose assessment is probably the most important thing you can do in an altered mental status patient. So make sure you get the blood glucose. Investigation in all caps. Hello, AEIOU tips. The time. O2 therapy because you want to maintain that 94% that as a result of probably their tongue blocking, and then upgrade to a captain after investigation leads to conclusion of postictal state. Right? And that, again, applicable to all AMS patients as well. Right? But here, this means that they've finished seizing. They're not seizing at all. They're in a confused state, and you're going through your AMS protocols anyway, right? And so there are multiple reasons to call, right? Someone could be ANO times 3, right? So you call captain anyway for any altered patient anyway. So like, I mean, there's a lot of reasons and a lot of overlaps. But if you know your very well written criteria for upgrade, this should be a walk in the park for you. Okay. Again, I cannot say this enough times, okay? We want to upgrade as much as possible, right? The captain will make sure that you guys aren't missing anything in terms of AEIOU tips, all right? Any type of psych patient, the pseudo seizures, they are a captain refusal, right? They're psych patients, all right? So the bottom line here is they're stable enough to talk to you without going back into a seizure, right? And they'll know, they'll tell you, oh, I feel like I'm going back. So make sure you ask them, hey, tell me if you're going to go back into a seizure. Right? They have an aura, usually, right? They can usually feel it. They know their body better than you probably do. So remember, stable enough to talk to you without going back into a seizure. Okay, RFD, that one's pretty easy, right? They have to actively be seizing. The patient not being able to safely and effectively get to the hospital due to being incapacitated, that is listed in our RFD upgrade criteria, but what I want to really relay is that they can't talk to you after investigating on scene for some time, right? They're like seizing, or there's something going on with them. They're not recovering from their postictal phase. It hasn't been enough time for you to comfortably say that, yeah, I don't know, right? You've probably called your captain, or their captain has probably responded with you. You guys have a discussion that, maybe this isn't like a regular postictal person where they're coming back, 10, 15 minutes after the episode. Maybe there's something else going on, right? So it's an active discussion, right? But you want to make sure you're activating RFD as soon as possible, right? So make your decisions quickly, be confident in your decisions, right? But remember your bottom line. They can't talk to you if they're seizing, right? But after you're investigating for some time and they still can't talk to you and they're altered for some reason, right? They could be having another seizure without you knowing, without the obvious signs of tonic-clonic, right? So there's a lot we don't know on scene. So remember, again, bottom line, they can't talk to you after investigating on scene for some time. You call RFD. Okay, I'm going back now. Cool. The anti-seizure medications, these are just common ones. Carbamazepine, that's Carbatrol or Tegretol. Sounds like Tylenol, but with the all. Just remember, people will tell you medications on scene. Write them down, and if you have like some type of free time, if you don't ask them, hey, what's it for? Right? If you just forget to, or you can't get that, and they just say one word like Carbatrol or something, then you can. I would always recommend that you just Google it real quick, right? It's 5 seconds of your life. It doesn't look unprofessional for you to pull out your phone if you need it, right? Just make sure you just put it away after. But just always look up the medication that you don't know, right? If you don't know what Dilantin means, or Trileptal, or clonazepam, or Neurontin, if you don't know what those trade names are, I mean, everyone knows, like, somewhat knows gabapentin, clonazepam, right? I don't think anyone knows oxcarbazepine, but if you do, good on you, right? Or the Dilantin generic name. Like, these are all names that we probably don't know off the top of our heads unless you're you work in this field of research, or if you're a doctor. So remember, look up the medications that you don't know, because the anti-seizure medications can vary from all types of breaths. People can take anything for anti-seizure medications as long as it works. So here's the point. Look it up. Okay, knowledge checks. I'm coming back for this one. How fun. Okay, so after an extended response time from CRA, let me get this out of the way. There it is. Extended response time from CRA to Canyon Creek south, right? So CRA, all the way up north down to Canyon Creek South, you find a 22-year-old male. Patient is sitting on the couch and can barely respond to your questions. Barely, right? And he doesn't remember anything within the last 20 minutes, seems very confused. Which mnemonic will you use to investigate his altered mental status? Please tell me. Pause the video, answer the question. Answer is AEIOU tips. Very good. Good job. Very good. Okay. Coming back. Let me move myself. I'm so sorry. This is probably better. Okay. You respond to a report of a 25-year-old female passed out at the plinth. Bystanders reported a seizure to UTD-PD dispatch, right? So they reported a seizure. The patient has regained consciousness and remembers a funny taste in her mouth just before she lost consciousness. She's also in a dazed and confused state. The patient is in the blank state, and the reported experience by the patient is called blank. Okay. Think about your answer. We'll come back to it and discuss it. Okay. If you pause the video, great. If you didn't, we're just going to move on and have that awkward pause. So the patient is in the postictal state, right? They can't be in a clonic state. They can't be in a tonic state because they're actively seizing. And what do you do if they're actively seizing? You upgrade to RFD. It's pretty easy on that front, right? So let's scratch number A and B, right? No, we're using test tactics, but whatever. So they're in a postictal state. And what's that funny taste in their mouth? That's an aura. Right? It could be lights, it could be flashing things, it could be confusing thoughts, it could be whatever, right? But in this case, it is an aura because it's a funny taste in our mouth. Okay, next one. I'm back. Sorry, don't know what to do. There it is. I have to move myself every time. Sorry. Oh, I'm so dumb. Okay. Respond to a call in the middle of Starbucks to a patient sitting on one of the benches, so those long sofa benches. The SU staff said that they called UEMR because the patient was convulsing and did not look okay, right? So they just, plopped over. Patient is able to respond to your questions, but is slow to respond and only looks at their friends as their, emotional support system. What disposition are you going to move forward with? Sorry, right? Patient is no longer convulsing. I will add that to this question because the patient is able to respond to your questions and is slow to respond. So they're not actively convulsing. What's it going to be? You may pause the video. We'll come back to it. The answer. Okay. The answer is a high-risk captain refusal. Why? Because the friend is in a postictal state. Right? They reported a seizure. You have to believe them probably if they reported a seizure. They may not know, but whatever, right? You got to go with what you're given, right? In that case, they're not actively seizing and they're able to respond to your questions. They're just a little altered, right? That RFD upgrade will be a consideration between you and your captain for sure. But at the moment, you're going with high-risk captain refusal. That way, as an in-charge, you make that decision with the captain so there's more minds on the kind of altered patient for sure. Right, the psychiatric nature of presentation, you don't really know and can't rule out all the life threats. Maybe you can, right? But if that gets to the point where you think it's psychiatric, there's a lot of medical conditions involved with pseudo seizures. Again, remember, pseudo seizures you kind of just don't want to deal with a lot of the time, right? So the PD release due to psychiatric nature of presentation, I would caution a little bit on that one, right? But can be a right answer if there is no medical issues and we can actually release them to PD according to our protocols. All right, but the right answer, the best answer is C on this one. Okay, moving on. I'm sorry I couldn't do the fancy knowledge check sideways on this one. I don't know. And I will not pop up for this one because it looks like there's no space. Okay. You arrive on scene of a 17-year-old male lying on the ground in the lobby of ATEC. The patient is part of a tour group, and there is a group of kids surrounding the patient. The patient is unconscious and has lost control of his bladder. Both arms and legs are contracting in a violent, rhythmic manner. Out of the following, which one should you not consider first? Right? So you can pause the video. We'll come back to it. The answer. Okay, so the answer... something that you should not do is calling the patient's parents before upgrading to a captain, right? That's just wrong on so many levels, right? He's unconscious, lost control of his bladder, actively seizing, right? What are you calling a captain for, right? You're going to upgrade to RFD for sure, right? D is the right answer, what you should do, right? B is a right answer because asking PD to help clear the scene, asking bystanders to step away from the patient, absolutely scene control, right? That's what PD's there for you. And ABCs, absolutely, right? That's what we're considering every time, right? That's the only thing we can really do. We can't stop the seizure. We just help them, maintain their ABCs. So C is something that you should not consider first. Even if the kid's 17 years old, you should not consider calling the patient's parents before upgrading to a captain. Maybe after you upgrade to RFD, maybe after RFD is on scene, if there's a parent that can do it for you, you can say whatever, you can go ahead and do it. I don't really know, right? But calling the patient's parents is not a priority for EMS at that point, right? And upgrading to a captain, there's no need to, right? You're going straight to RFD. Okay. Good job on that one. I'm popping back in just because I like to and it's fun. Okay. You respond to a call at the activity center. I'm so dumb here. Sorry. Oh, God. I'm so sorry. Okay. You respond to a call at the activity center for a patient who fell and hit her head after trying to dunk a basketball. Her intramural teammate said she was seizing prior to your arrival. The bystanders say that the patient has no history of seizures for as long as they've known her. Right? The patient is now conscious and able to answer questions. The seizure may have been caused by what? And the patient disposition should be what? Here's a fun part, right? This is where you have to know your upgrade criteria. So answer the question. You can pause the video, and we'll come back to the right answer. Okay, so I'm looking at the upgrade criteria right now, and I want to show you guys something on the... I can't show you. I'll just read it to you all, right? But here's the best part. It's if you sustain a head injury, but if you're symptomatic, right, you absolutely have to upgrade to RFD. But here's another one. Experience a significant mechanism of injury capable of sustaining serious injury, and serious injuries cannot be ruled out. She had a seizure as a result of a head injury, right? That's out of your depth. What are you going to do? Right? You want to make sure that she's checked out by a higher level of care, right? And you're the preventing factor from that, right? But again, head injury, symptomatic, right? She had a seizure. You got to upgrade for sure. All right, but there is gray area. So again, you'll have that discussion with your captain. For sure, they will probably upgrade to RFD if I know all V captains, all my colleagues very well. So yeah, again, a discussion, right? But the right answer in this one is C. The seizure may have been caused by head trauma and should be an RFD upgrade due to symptomatic head injury. Okay, do I have one more? I do not have one more. That is it, ladies and gentlemen. Thank you for watching. I hope you guys really enjoyed the video. It has been fun. Again, if you have any questions, you're more than welcome to reach out to your field training officer, and you're more than welcome to reach out to any of the captains for a discussion on what do you think an upgrade would be. But this video is a tool for you guys to kind of further your knowledge of what it looks like on the EMR side. So I hope I answered most of the questions that you guys may have had in terms of kind of altered mental status seizure patients. And yeah, we'll catch you on the next one. See you later.